Welcome to this Autism Ontario webinar, Psychiatric Medication Use in Autism Spectrum Disorder. My name is Matthew Lay, and as always, I will be your host. With more than 75% of individuals with autism spectrum disorder will have trialed a psychiatric medication by adulthood. And so it makes sense that we take some time to talk about this subject with, joining us for the first time on the desk, Dr. Amanda Sawyer.
Hi.
Thanks for coming. Dr. Sawyer is a child and adolescent psychiatrist at the Center for Addiction and Mental Health, Hull and Bloorview. She's also a lecturer at the University of Toronto with extensive experience in working with those on the spectrum. So today what we're going to try and do is understand the prevalence of psychiatric medication use in individuals with autism spectrum disorder. We're going to develop an approach to deciding when psychiatric medication may be appropriate. And we're going to develop an approach for evaluating positive and the negative effects of said medication. Before we dive in, though, I've got a few ice-cubing items. One of my big jobs here is to keep the conversation going and get your questions answered. Please submit your questions at any point in time using the Ask Question box. They'll come up to my iPad, and I will do my best to get an answer for you. As is always the case, we are unable to answer specific we can't give you specific medical advice. There's just not enough time. And as you'll see today, there's a lot more information that is needed to do that. But we will do our best to point you in the right direction and answer your questions to the best of our ability. Or at least Amanda will. If you have any problems, click the help button. And from time to time, I will be referencing resources that help inform our conversation, allow you to dig deeper into some of the topics we are discussing. All right. So with all that out of the way, let's get started. I think, stole your thunder since it was on one of your slides. And I talked about this. What I found was a pretty staggering stat. I imagine 75% is higher than what we see in the general population.
Yeah, I focus all of my practice on individuals with autism, so I don't know the exact number of everyone else, what the percentage of the general population who will have trialed psychiatric medications by adulthood. Yeah. But greater than 75% of individuals with autism spectrum disorder having trialed a psychiatric medication is a large amount. Yes. There's probably a reason why that is. Right. Medications can be really helpful for an individual with autism spectrum disorder in certain scenarios, which we will talk about today. But it is probably a higher percentage than we would like to see. Okay. For those of us who don't have MD or all the other letters behind our name that you do, what are we talking about generally when we're referring to the medications? So what we're talking about today is we're talking about medications that will help with behaviors or mental health issues. Okay. So I'm talking about violence, aggression, irritability, sadness, anxiety, psychosis, bipolar disorders, everything that you might see in what we call the DSM-5, which is our Bible of Diagnosis for psychiatry. But also when it comes to autism spectrum disorder, there are behaviors that are treated with medications as well. Okay. So you did a study, and the study, talk us through the study and what it is we have on the screen for us right now. Well, I did the study with other people. That's okay.
You were involved in the study.
I was involved in the study. Joanna Lake was the head of the study. Yeah. What we did was we sent out a survey to 100 families in Ontario who have a child on the autism spectrum. And we asked, what medications are you using? Right. And then what we did was we compared adolescents to adults with autism and to look at what medications are they using. We found out that throughout the board, whether or not you're an adolescent or an adult, there's somewhere between a 50 and 60% chance that you'll be on an antipsychotic medication, regardless of your age. Okay. But what we also found out is that in the adolescents, they were more likely to be on an ADHD medication. And in the adults, they were more likely to be on an anti-anxiety or antidepressant medication, which actually makes sense with how psychiatric disorders go within the age. Okay? We also found that there are a proportion of people who are on multiple medications, and that both the adults and the adolescents had a higher chance of being on multiple medications as well.
So I meant to do this earlier, but we talked about your experience and your credentials. But can you just talk a little bit about your practice and where you're coming from? Because you do primarily those on the spectrum,
Yeah.
correct? Okay.
So I have a tertiary care practice, which means that I'm in a big fancy hospital, and we only see really the most difficult cases. My practice primarily focuses on people with autism spectrum disorder.
Okay.
I see people throughout the lifespan. So if I think about it, the youngest person I've seen in the past 2 years is 3. The oldest person who I've seen in the past 3 years is 65.
Okay.
But I like to focus, because I'm a child and adolescent psychiatrist,
Right.
I focus a lot of my practice on the child and young adulthood.
Okay.
And I see people who either have a diagnosis of autism and they're questioning whether or not there's an additional mental health issue. I also see people who have mental health issues and someone's questioning whether or not they have an autism diagnosis.
Right.
And I might look to see whether or not it's valid. Once I see them and I figure out perhaps what's going on and what issues might be there, then I could approach things like medications, behavioral approaches, therapy approaches. I might not be the one who's implementing them or following through with them, but my job is to help create a formulation of what might be going on. And our job today is to discuss how would you
Right.
formulate what's going on, and then how do you decide whether or not your medication decision is beneficial for either your child or yourself.
So I'm going to get ahead of a question we're probably going to see.
Yes.
How many of you are there out there in Ontario?
I'm not going to answer that
Okay,
question. We are a special breed.
Right.
I think the point is, though, there are a subset of us who
Yeah.
do specialize in seeing people with autism. However, there's a lot of people with autism and a small amount of people who specialize in autism.
Right.
What our job is...
You're not saying anything no one else
I know,
can.
I know. What our job is to educate other people
Yes.
how a regular family doctor, a regular pediatrician, a rural doctor, a rural pediatrician can better work with people with autism spectrum disorder.
Yes.
And what I'm hoping to do today is empower everyone to help communicate in a different way with their healthcare provider to have an appropriate conversation about what role medications may have in their life.
Right. Since your practice is primarily those on the spectrum, when the study that you were a part of,
Yeah.
you got all the data back,
Yeah.
did this surprise you, what you saw?
No, this doesn't surprise me. What I find in my practice is basically the older you are, the more medications you're on or the more medications you've trialed. And I find a lot of people who are on antipsychotic medications, stimulant medications, or who've at least trialed these medications.
Mm-hmm.
That being said, I do see complicated patients. So
Right.
I do see people who have perhaps standard approaches haven't worked for them.
Right.
So I might see a biased view, but this study actually shows that my view that I do see is probably more consistent across Ontario as well.
Okay, so medication has a role. We're going to talk about that today. But one thing that medication is not is it's not a superhero, right? It's not gonna fix everything if you just find the right one.
So what I see in my practice is I sort of see 2 points of views.
Okay.
One point of view is that if you just give me this magic pill, everything's going to be better.
Right.
That's not true. There's no magic pill. There's no pill that cures autism. There's no pill that's going to create all mental illnesses or all behaviors to go away. On the other side of my practice, what I also see is people who say, I am anti-medications.
Yes.
There's no way I'm going to prescribe this medication. I'm at a psychiatrist's office, but I'm anti-psychiatry. I'm anti-medications.
Yeah.
And I want to, hopefully through today's talk, I want to create more flexibility in that view too, because medications can have a very important role. They're not the only solution, but they can be part of a package of solutions that can help improve quality of life.
Right, and I mean, you hear this I'm sure not just within this community, but everywhere. A lot of people have a stigma with these types of medications, and I think you gave a great example about, if you have a broken arm, would you have a stigma about having a cast? If you had cancer, I mean, medications are there for a reason.
Medications are there for a reason, and hopefully through talks like this, we open up the conversation about medications, and we don't say, oh, you're on a psychiatric medication, there must be something really wrong with you.
Right.
No, you're on a psychiatric medication because you need it, it's helpful for you, and it's helping you live the best quality of life that you want to live.
Right, and what we're going to do now is we're going to get into that process. As a reminder, you can submit your questions at any time. Those questions will come up to my iPad, and I'll aspire to get you answers to those questions. But we are going to talk today about formulating mental health and behaviors that challenge. Formulating is a big and fancy word. So before we get into this. What do you mean when you say formulating?
So my goal of today's talk is not just to say, hey, medications are awesome, or hey, medications are horrible.
Right.
What I want to help parents and individuals do is figure out a way of how to approach mental health issues and how to approach different behaviors to figure out whether or not medications may be required or needed.
Yeah.
So what I'm talking about when I'm talking about formulating is taking a step back and not just saying, hey, my child is hitting, I need a medication to solve the hitting. Saying, hey, why is my child? Why am I doing this?
Okay.
And I have a standard approach that I use in everyone who comes into my office of how I look at this.
Yeah.
And I'm also hoping by talking about it today, perhaps even going into a doctor's office, you can be thinking about these different approaches as well.
Okay.
And the categories that I think about when I'm thinking about mental health is I think about how might health be playing a role in this person's presentation? How might their environment be playing a role in their presentation? How might their lived experience be playing a role in this presentation? And lastly, how might psychiatric disorders be playing a role in this decision? And what we'll do is we'll go through each category and talk about how those might play roles in an individual with autism or your child's life with autism. Above and beyond just psychiatric disorders.
So did you invent this? Is this something that only happens at your,
No. So what I'm doing when I go through, it's called a HELP model.
Yeah.
This was actually created by Elspeth Bradley.
Okay.
It's on the Canadian Guidelines for Primary Practice Care for People with Developmental Disabilities website.
Right.
You can find it on the HCARD website. You can find it on the Surrey Place website. And it's a published approach that's supposed to be a standard of care of how do you approach behaviors that challenge, what used to be called challenging behaviors. So you could find this on any of those websites, and it is actually an approach that has evidence behind it. It's not just an approach that I made up, and I have lots of mentors and people who've helped me figure out how to use this approach appropriately.
Well, I'm sure even if you made it up, it would be evidence-based. You can get to that through the resource section, autismontario.com or learning.autismontario.com. Okay, let's get into it. So the first thing that you want to talk about is the ABCs, start at the beginning of the alphabet, but that all behavior is communication. What are you meaning by this?
So when I say remember your ABCs, I remember all behavior is communication. So people will come into my office and say, my child's hitting, I feel so sad all the time, I can't do university. And what I need to do is take a step back and think about what is that behavior communicating? What is that mental health symptom communicating? And by taking that step back and looking at this model that we're about to talk about, we will better be able to understand why the person's presenting the way they are.
Okay. So one of the things that, we know, and we've talked about it a lot, are other medical problems that are very common, right?
Yeah.
So what are the sort of things that you look for?
So I want to say that when I first started this approach and I was thinking about medical problems in people with autism, I was thinking, hey, this only has to do with people who are nonverbal with autism. But as I've developed my practice and as I've seen client or patient with autism, I've actually realized that throughout the spectrum, you actually see medical problems presenting as behaviors or mental illness.
Okay.
So the way that I think about this is if I have a cold and I go to work, I'm not going to be able to perform in the same way as if I'm feeling 100%.
Right.
If someone with autism has a medical issue, they also won't be able to behave or function in the way that they would normally at baseline. However, there's also other stressors that are happening in their environment that might cause the medical issue to have even more of an impact. As well, someone with autism may not be able to communicate their medical problem in the same way that someone not on the autism spectrum might be able to communicate.
Okay. It's not on here, but I'm assuming a lot of times when you're seeing people that are already on medications, do you also look at the side effects of those medications?
Yeah, so actually one of the most, so there's several medical problems that I'll look at when I have someone in my office. There's very common medical problems that I see. So for example, constipation I see all the time.
Right.
Pain issues is a common reason why people may attend the emergency department. I have people who have had very high levels of sugars, very low levels of thyroid, And if I was to just say, hey, here's a medication, that's not going to fix the sugar problem. That's not going to fix the pain issue. That's not going to fix the constipation. There might actually be a different type of medication that you use for that. But another approach that I use is there actually, when someone comes with a long list of medications, might there be a medication side effect that's actually causing some of the behaviors? So are they on a medication that makes them feel drowsy and foggy? Is this individual able to communicate to me that they feel drowsy or foggy? And might actually a medication that the person is on actually might be causing harm because of the side effect? Or is that medication might actually just be doing good things? And we can talk about that further. In future in the talk.
When you started, though, you talked about how some medical problems, I guess symptoms of medical problems can display as mental health issues. Can you give me an example, maybe, that you've come across where it's like that?
So some examples that I've had is I've had people who have broken limbs. And their caregiver might come in and say, they used to dress independently, and now they're not dressing independently. And then we do a physical exam, and we're like, wait a minute, why aren't you using that arm? Oh, maybe we should get that checked out. Oh, that's actually might be a broken arm. Let's get that cast, and then they'll use it again. But there's a lot of things that are more long-term. So, for example, constipation doesn't come up overnight, right? So if you are like up to your head in stool within your belly, and you're always feeling bloaty, every single time you have a bowel movement, it hurts. Eating doesn't feel really good. Walking around doesn't feel really good. That's sort of a slow burn problem that people might be irritable for long periods of time because they're actually not feeling very well. And again, like that person, if I just say, here's a medication that might actually cause more constipation, I might be adding to the problem as opposed to solving the problem. It might be that I say, okay, go to your family doctor, get really well cleaned out, and then maybe the irritability will still remain. And I might need to give a medication. Even though we've already solved the constipation issue, there might still be other mental health or issues that are there, but at least I could know that this part of their presentation is fixed.
Great. So we had a bit of an issue getting questions to me that just got fixed. So before we move on, I'm going to ask you a couple questions, so I apologize for that, guys. 75% and the like, do you feel that psychiatric medications are an inevitable part of ASD development, or can naturopathic treatments be an option?
So I'm not going to comment on naturopathic treatments because I'm not a naturopath, so I don't know the evidence, and you'll have to ask someone else for that part, but I can talk about whether or not psychiatric medications are an inevitable part. I have people in my practice who've never been on psychiatric medications and are doing well not on psychiatric medications, or with changes in the environment, thinking about their lived experience, which we'll talk about later. We've been able to take a therapeutic approach or a behavioral approach, which has actually avoided medications. So not everyone on the autism spectrum is going to need medications. Hopefully there's also other treatments that can work either in combination with medications or instead of medications. So I'd like to hope that not everyone will need to be, but there is a good set of population that do need to be on those medications and are on them for a reason.
And I mean, the numbers indicate it is 2/3, right? Or 3/4. Is my math's off. And I mean, this isn't often a question I think that parents, and we all feel if we're ever diagnosed or given a medication, is it possible for a child to outgrow its need?
Yeah, so if you look at the studies, one of the biggest predictors for being on medications in adulthood is actually being on medications childhood. And so you have to look at what is the reason why this person is on the medication. If they're on the medication because it's a behavioral issue, and we were able to work with a behavioral therapist, or we were able to put some strategies in place, or we changed some of the things that we'll talk about in a few minutes, maybe they don't need it. And we'll talk about coming off of medications as well. But some people have different mental health diagnoses that actually might predict that they might need medications long-term or throughout their lives. So what I tell parents is it's not a goal for me to say, hey, we're going to be on this medication so you can be off of it for a year. We say we're going to be on this medication so we can improve your quality of life. In the future, we might look at decreasing the medication. But if we decrease the medication and the symptoms come back, that means that the person actually needs medications, and we need to respect it. We wouldn't say, hey, my child has diabetes, maybe their pancreas will regrow insulin, so then they don't need it anymore.
It's just a lot easier
right?
in that case, right? Because you have that test that says that they still have the
Yeah.
diabetes.
Yeah.
But in this case, I know you're going to show us a little bit because I've been through this presentation before, but
Yeah.
I know that it's a lot harder.
Well, another thing that parents might say is, hey, you know, every single time my child's anxious, they come off the medication. Every single time they come off the medication, they're anxious again. They're addicted to the medication. I don't want my child on this medication because they're addicted. My perspective is not that they're addicted, that this medication actually might be helpful,
Right.
and that there's a good reason why they're on medication. So coming off of a medication to me isn't my #1 goal. My #1 goal is helping quality of life.
Right. Have you ever seen it where a medication causes more anxiety when it's supposed to be decreasing it?
We'll talk about that
Perfect.
as we
All
go along.
Okay.
We will definitely talk about that.
So we've handled a few. Now we're
Yeah,
going to move
yeah.
on to the next part of the process that you go through, which is environmental stressors. And we're talking here about expectations, it looks like.
Yeah.
Okay.
Yeah. So a common thing that I see is that in life's changes and stages, and as people grow older,
Right.
expectations change.
Yep.
So for example, the expectations you have on yourself or on your child as a 2-year-old isn't the same as it is as a 12-year-old, isn't the same as an 18-year-old, isn't the same as an adult. One of the complicating factors of autism is that timeline where those expectations should be met might not be the same as the timeline for someone without autism or someone without a mental health illness.
Yeah.
So what's really hard for individuals and parents to sometimes do or accept is figuring out what might be a time where you're actually putting too much expectations on the person, and what might be a time where you're actually putting too little of expectations on a person, and may that actually be causing the mental health issue that's happening right now. And when I'm talking about environmental stressors, I don't care whether or not you have an intellectual disability or if you have a genius IQ. It's really important to look at what aspects are too much, what aspects are too little, and when you have a mental health issue that's coming up, you might not be able to handle or carry as much as you might have been able to handle or carry before.
Right. And some time ago, we had an author on the desk, Ross Green, and he wrote a book about this idea around behavioral issues in children being an issue of expectations and skills not being aligned.
Yeah.
And if you want to dive deeper into that, you can find that archived webinar at learning.autismontario.com. So can you give me, though, an example of this?
So
like
maybe let's
what you're
move
saying?
forward to
Sure.
the next slide, and it will give some examples.
Perfect.
So if I am someone who has a diagnosis of autism and I'm going off to university,
Right.
okay? When I'm in my home, I might be able to do my own laundry. When I'm in my own home, I might be able to study and get really high grades. But then what might happen is I might say, hey, you know, I've accomplished so much. Look how good I'm doing in academics. I got into this really prestigious program. I'm going to go away to university and I'm going to live on my own.
Yeah.
Then what might happen is all of a sudden, while there were expectations that you might have been able to do on an individual basis, all of a sudden adding on one more task, so living independently, might make it so that you can no longer do all the things that you used to be able to do. So all of a sudden it's too stressful to balance getting to university, paying bills, doing your own laundry, and cooking. And for someone like that, it might be quite a surprise because this person has such a high IQ, they've been doing really well, but executive functioning skills might not be at the level that needs to be to live independently.
Yeah.
And what I see sometimes happens is in that individual, they'll say, oh, well, I wasn't meant for university, or I just shouldn't do this anymore, I should give up, I'm a failure.
Yeah.
When really what it might have been is there was just too much on that person's plate.
Yeah.
And by taking away some of those responsibilities, so for example, getting student services involved, maybe getting some help with cooking or cleaning, you might actually be able to handle the task ahead and be able to do university.
Yeah.
If I give an example for someone who might have an intellectual disability, some things that sometimes happens with parents is that as the child gets older, they want them to do more and more skills, which people should be doing more and more skills, right? But it's hard to gauge what skill actually might be too advanced for that person versus what skill might be too easy. And so you might say, hey, my child loves cooking. I'm going to let them start making sandwiches for the family. And when they're making sandwiches for themselves, it's actually a really good task. They have a lot of pride. They do really well. But then all of a sudden when you say, okay, no, there's 5 people in my family, now you have to make 5 sandwiches, that might be an expectation that might be too high for that individual. It's hard to tell which expectations might be too high. My advocacy is to do it in a stepwise approach where you're adding on a little bit more, you're adding on a little bit more. Don't be afraid to challenge people with autism to be able to say, hey, let's figure out how to live as independent as life, as fruitful of life as possible. But also when you've sort of overshot your mark, don't be afraid to dial back down as well.
Yeah, it's not failure, it's just where they're at.
Exactly.
Sort of we are getting a lot of questions about medication. And I think that it makes sense for us to get through this process before we address them. So we're not ignoring your questions, keep them coming. But what we're doing now is talking about everything that happens before the step of medication. And you may not have been through this process, so we want to get through this before we get on to
And just want to say, just because these issues are going on doesn't mean that your child doesn't need medication. What I'm saying is you need to understand these issues along with the mental health issues, because there might be other approaches along with medications that you might be able to take.
Okay, so I found it interesting that 2 slides ago we said that we were aspiring too high or too low. What does too low look like, and how does that affect people?
So no one likes to sit at home doing nothing all day, right? So when we were talking earlier, we were talking about sometimes I just love taking a day off and watching Netflix. The first hour, it's great. The second hour, I'm like, wow, this is such a luxury. Like, I've never get to do this. And then I get to the end of the season, and I'm like, whoa, I really don't feel well. Like, this day just sucked. I'm drowsy. I'm tired. Maybe I should have done something other than watch TV all day. I think sometimes with individuals with autism, we forget that they actually need stimulation. It might be a different type of stimulation that they need than perhaps maybe what their parents need or what their sibling needs, but stimulation is needed. So, you know, I see very well-meaning parents who do everything for their child, but sometimes as your child gets older, they actually want to do some of the things themselves, and it might be a good idea or a good task to be able to say, hey, let's figure out how to teach you how to do more expectations. Another time where I see this coming up a lot is when people transition from schooling to programming, or that gap between schooling and programming, and all of a sudden there's nothing to do all day. I see a lot of irritation and agitation happening because people are bored. And then unfortunately what happens is then the day program or the programming that you're looking into says, hey, there's too much behavior, we can't accept them. And an advocacy might be to say, hey, actually the reason the behavior is there is because they're not doing anything all day, and when they were in school and they had a regular schedule, they were actually really doing well. So maybe we could try it and see if that stimulation or higher expectations might be helpful.
Okay. So the last stage here is...
we missed a slide. Because there's a really important thing to talk about. Oh, I didn't miss it. I just put it in the wrong order. One of the important parts that I want to say is that when you're thinking about what expectations to either put on yourself or put on others, accommodations are key. Assistance and accommodations are key. Everyone wants to be independent. Everyone wants to live a fruitful life. But if you just say, here you go, be independent now, that's not setting people up for success. Don't be afraid to use as much assistance or accommodations as needed. It will help you be happier and achieve more goals in life. On the same end, you also have to think what goals are actually realistic for being independent in. So there might be some goals that you achieve or strive to do, and it just might not be realistic, and an individual might need assistance with that for the rest of their lives. So it's important to say, hey, how can we accommodate? How can we assist? If we accommodate and assist, maybe they will be able to do it independently. If we accommodate and assist, we might need to accommodate and assist for the rest of their lives. Or this might be something that's just not worth putting our time and energy in because this task might actually be too hard for them.
And that's a stepwise approach, right?
Stepwise approach. Yeah, because one of the most complicating aspects about expectations is a lot of the times there's this balance of some aspects are too much expectations and some aspects are too little expectations. And it's hard as you're tweaking to try to figure out where that right balance is, but spending that time on figuring it out is really going to be helpful for yourself, is really going to be helpful for an individual with autism, and could make future life much more pleasant.
Right. So if you can imagine this, this is all being done before we get to diagnoses and prescribing medications. There's a lot of steps that is outlined here. So the last thing you looked at is lived experience, like what's just occurred in their life or what's going on in their life.
I think that people forget that people with developmental disabilities, people with autism, actually experience life. You know, there's so many cookie-cutter services that happens. There's so many cookie-cutter programs. People say, oh, here's the formula, here you go, done. But really, people with autism live in this world, and there's lots of stressors in this world. And people with autism may understand stressors in different ways. So for example, one of the examples that I think about is the school setting. School has fluorescent lights, there's lots of noise, there's bells all the time. It might actually be sensory overload and traumatic for someone to be in a school setting every single day when there's so much sensory experience. Maybe that overstimulation of school is making it hard for that person to say, hey, I want to move on to the next step, because they're not used to that environment being very good. And if you say, hey, let's talk about how school was difficult, or if someone's nonverbal, let's think about how we could create a different environment that may be comfortable for you. And see whether or not that lived experience may be able to change. Another thing that I think about with lived experience is as people grow up and as people age and change, they might start to notice that there's differences between themselves, their siblings, their peers. And people like to gloss over that, right?
Yeah.
But it is actually important to say, hey, like, I know this might be difficult for you, or hey, let's talk about how you're experiencing this. A common example that I see is when a sibling is moving out of the house, or her sibling's getting married or going to university, and the individual, whether or not they're verbal or not, might start to think, hey, am I actually going to meet that goal? Hey, maybe I'm actually really sad that my sister's getting married, because that means that she's actually not going to live with us anymore, and I really enjoy her living with us, but I might not be able to communicate that. Another lived experience that I see commonly happening in individuals with autism is deaths. People not spending the time to talk about the impact that a death might cause. But a smaller version of death, but one that still has a big amount of impact, is loss of a caregiver or loss of a peer. So a lot of people have respite workers, caregivers, teachers that play really important roles in their lives, but at the end of the day they're a paid employee, so they may come or go.
Right. And
explaining to the individual why that person is leaving, if you can, having a good goodbye, can make lived experiences better as well.
So when so we do a little pre-interview, and when you brought up some of these, you know, I went to the folks at Autism Ontario and I said, they seem like kind of simple. Like, these are things that you would imagine would be trigger, oh, something has changed. But I think that maybe, you know, what they mentioned to me is sometimes they don't look at, like, a death, for example. And that could go back to lower expectations. Like, maybe they don't think they understand it, or not believing, or
they might not understand that that's as big of a loss, right? So, you know, if someone, they might not understand that changing your roommate is a big deal because it had to happen because of budgets or housing, or you know, that maybe that other person was bullying the person, and they maybe thought, hey, that it was actually a good loss, but the person might actually miss them. It seems bread and butter, but it is something that often does get overlooked.
Right. So basically what's happened now is we come into your office, you've looked at the behavior that we are looking to address, you've looked at, made sure that they've got any medical conditions that you might figure out, send them to their doctor to get that handled if need be. You've gone in and you've looked at the what's going on in their environment. We've looked at lived experiences, expectations, and it is only now that we get to the point of diagnoses.
Yeah, and I'd like to say that you can have a psychiatric diagnosis and the expectations are too high or too low. You can have a psychiatric diagnosis and a medical condition, and perhaps the medical condition isn't getting better because the psychiatric diagnosis is making it worse, right? So I don't think these are, they say if you have this, you can't have that.
Right.
They can actually work together, and they can actually make each other worse.
Right.
My point is that before jumping to a diagnosis, you have to make sure that you fully understand holistically what else is going into the person's life.
Right.
Because if you just say, hey, they're sad, they must be depressed,
Yep.
you're missing a part of it. You can say, hey, they're sad, their dad just died, you know, they've lost their day program, lots of things are happening. But I think the sadness is actually above and beyond just typical sadness.
Yeah.
Depression might be an aspect for it of this, and the treatment for depression might be really important.
Right.
Or you might say, hey, you know, their dad just died, they lost their day program, they're really lonely all day. Actually, that sadness isn't really having other symptoms that go along with depression, and maybe it's not depression.
Yep.
And as psychiatrists or doctors, we actually have this book called The Diagnostic and Statistical Manual of Mental Disorders that help us understand whether or not this is just typical sadness, just typical worry, or whether or not it is actually a depression or anxiety. So it's up to you as an individual or you as a family member to help explain the other symptoms that are going on above and beyond sadness, above and beyond the worries that might make this not just a typical experience to the situation they're in, but above and beyond and a psychiatric disorder.
Okay, we're not going to talk about the diagnoses. We're going to get into what it seems like a lot of people want to talk about.
Medication,
and that is medication.
Okay.
So I got one question here that we can take before we dive into that, because it has nothing to do with our process. I guess it's an opinion question. Is how young is too young for medication?
So the youngest person in my practice is 3, the oldest person in my practice is 65.
Okay.
I don't think there's too young for medication.
Okay.
I think the younger you are, the more careful you have to be with medication. I think the younger you are, perhaps the more monitoring there is might be needed for medication. But there's no age that says, hey, this is the age that you can't prescribe medication for.
Yeah.
What we have is we have several organizations that help mandate sort of age for different medications.
Okay.
So, for example, we have the Food and Drug Administration will say, we approve this medication for this age to this age.
Yes.
And so there's certain medications that you might be using that are off-label or not approved in Canada for that age group. It might be that your doctor decides to use it because perhaps there was a study, perhaps there's an experience, perhaps you're desperate and this seems like it would work. But the parent has to understand that in that young child, it's actually an off-label use.
Right.
And we don't necessarily know what the side effects, good or bad, might be for that medication. But if the situation is warranted, you can always trial it with careful monitoring.
Right.
The other thing to know is that the younger you are, the more side effects you might have to a medication. So you might trial a medication when you're 8 or 9 and have really bad side effects, not be able to tolerate that medication. And then when you're 15, 16, 25, 30, you might go back and trial that medication again because your brain and body may have matured in a way that they can now tolerate that medication. So just understand, if you're using medications at a young age, it's not impossible, it's often off-label, it needs closer monitoring, and just because it doesn't work now doesn't mean it might not work in the future.
It costs over $1 billion in this country to bring a drug to market, and part of that is all of the trials that occur so that the government can state this age group, this use case, that sort of thing.
Well, if you want to talk about stigma, one of the stigmas that often happens is there's not a lot of studies that show, hey, this medication is really good in autism, right?
Yes.
And the studies that I have are so small that if it was any other disorder, no one would say, hey, that's the pivotal study that's going to say this drug is approved. But what we're doing is we're working off as much evidence as we have. The evidence isn't large, and there's not that much funding to say, hey, this is a medication that works really well for anxiety in a 15-year-old who also has a diagnosis of autism. So what I might do is I might say, hey, this medication has evidence for anxiety in a 15-year-old.
Right.
I'm going to borrow that literature from 15-year-old anxiety disorders and say, maybe it will work for autism as well.
Right.
But the studies aren't there, and
Yeah.
that's why a lot of the medications will be off-label.
Yeah.
And that's why there's a certain amount of educated guessing that might happen in choosing medications, and you might not get to the right medication on the first trial.
Right, and we're going to talk about how we sort that out through the monitoring process. The reason I was bringing that up only was just to state that there's a lot that goes into the country saying that it's good for a 15-year-old
Yeah.
or a 12-year-old, right? Okay, so a lot of how we're going to address your next questions about medication, changes in medication and possibilities is through how you monitor the use.
Yeah.
So how do you guys go about this?
So my first thing that I want to look at is what is the target that you're hoping medications will help with. Okay? And I think one of the places that healthcare providers and families often get into arguments with about medications is you might say, hey, this is the target that I want to address. And the healthcare provider might say, hey, actually, that might not be an appropriate target. That might not be a target that medication might be able to solve. That might be a target that some other intervention might be able to solve. And I want to give credit to GPs and to people who don't deal with autism all the time. They might not know what that other intervention might be, right? So it could feel as a parent or as an individual really disempowering when someone says, hey, I don't really think there's a medication that's going to help that, but I don't really know what that next step is, but at least they're being truthful.
Yeah.
The other thing that I find sometimes happens is that what the healthcare provider thinks is a good target and what the parent might think is a good target for the medication might be on two different road paths.
Right.
So I might say, hey, here's a medication. It's going to work really well for anxiety. Here you go. And you might come back and I might be like, wow, look, that anxiety is really, really much better. But the parent's like, well, actually, I didn't really care about the anxiety. I cared about pacing a kilometer a day, right? That's an example of a medication that might have a use, but there was a miscommunication of where the target symptom might be. And I might say, hey, actually, it's really hard to help pacing with medications. And don't take these examples as the gospel truth, because there may or may not be a medication that's useful for pacing, but it just might have been that medication wasn't the right target and we miscommunicated, or it might be that that's not a good target for medications.
So you got to make sure when you're having that conversation with your doctor that you both have the right targets.
Exactly. And then the other part to think about is what is the frequency of the symptom that the person is having? And is that symptom regular enough to actually be the right target for a medication?
Okay.
So an example that I might give is violent behavior.
Right.
Okay? If someone's having violent behavior once a month, and then we give someone a medication that they take every single day, that medication might not actually target the violent behavior really well. That might be an example where that once a month, something might be happening in expectation, something might be happening in lived experience, something might be happening in health. And I might want to take a step back and look at my formulation again to see why that might be happening. But if, let's say, the person is really, really, really anxious every single day, and as a result of that anxiety every single day, after 29 days, a volcano erupts, I might say, hey, instead of just focusing on violent behavior, let's focus on that anxiety that's happening every single day. Because if I just say, hey, I'm going to get this target behavior that only happens once a month, it's really hard to tell whether the medication is actually helping or whether or not it's that the stressor isn't happening. If a medication isn't happening frequently enough for you to be on a medication that helps every single day, that might be a time where you actually talk to your doctor about taking an as-needed medication or PRN medication that you take in the situation as opposed to taking every single day. Right.
So I got to imagine that it's hard when someone walks into your office and says, last week this thing happened, and for you to figure out and unpack all of that. So you need some data, right?
Yeah.
Okay.
So one of the things that we were talking about before is it takes a long time to see a physician, especially if you're in a rural community, even when you're in the big cities. you're not going to have this issue and then you're going to see a doctor or a specialist or psychiatrist the next day. There's usually a period of time between when the issue happens and when you get to see someone who can help you with the issue, which is unfortunate, and I wish that wasn't the truth, but it is a reality of our system. So one of the things that you can do is you can choose target symptoms, and even before you go to the physician, monitor how often they're happening. So this might be an example of things that you might monitor to see what's happening at baseline. And a really important part that you want to do when you're monitoring the behaviors is you want to put a way that you could monitor it in an objective way, and you want to describe what's happening.
Okay.
So for example, I put mood 1 to 5. That was actually not a very good description of what to do, because I don't know what 1 means and I don't know what 5 means. But what you might want to do is you might want to say mood 1 to 5 on in a different paper, describe what a 1 looks like, what a 2 looks like, what a 3 looks like, what a 4 looks like, what a 5 looks like. So anyone who's looking at this document can say, hey, this is what's going on. The same thing with hitting. You might not just say they hit 5 times a day, but it's like this. You might want to say they hit 5 times a day and it was really intense bruising, or they hit 5 times a day, 3 times was a tap, 2 times was really hard and someone really got hurt. So you get an overall frequency, and you also get an intensity or a description.
Right.
Another thing about collecting this data is sometimes parents will come and it will be 11 months wait list to see me, and they'll come with 11 months of data piled this high, and they might get frustrated because I don't know what to do with that data. So it might also be helpful to do things like graphing it or showing how it changes over time, sort of summarizing that data, but also bringing both that summarized data and also the raw data so that someone can see what's going on. And I might say, hey, in January, there was a really big spike of behaviors. Why don't you show me the raw data? And I might look at that as opposed to spending time shuffling through 11 months of data.
If someone comes to see you and they're on no medication, and you're thinking about prescribing medication, do you have them do this before? Do you send them back and say, go do this and then come back?
Maybe I should. So a lot of parents, parents and families, by the time they see me, they tend to be quite experts of their child. A lot of families do come in with this. A lot of families actually need support to do this. So I won't judge them if they come in with this or if they come in without it. What I sometimes do in my office is when I'm not quite understanding what's going on, or I'm not understanding things like intensity or frequency, as they're talking to me, I'll write down on a piece of paper the symptoms that I see might be targetable by a medication, and I might write it out and say, hey, come back in a month, come back in 2 months, and so we can see the baseline, and then we'll start a medication, and we'll see what happens. The flip side of that is not just what if someone comes in not on any medications, but what if someone comes in on a list of medications, right? How can I use this? So what I might want to say is, hey, they're on this list of medications. Let's not touch any of these medications right now. Let's get the target symptoms and see how often and how frequently and intensity they're going. And then let's make medication changes and see whether or not things get better or worse.
And either way, that's what you're going to do, right? You're going to make that change, introduce or remove, change or whatever, and then you're going to have them do the exact same process. So we've got 2 here that I can flip between. What are you seeing when you look at the baseline and then the post-medication of this person?
Let's go to the baseline first.
Sure.
So when I'm looking at this, what I see is this is a person who's 5 out of 7 days of the week is hitting someone. They're hitting someone between 1 and 5 times a day. And then let's say I start a medication or I remove a medication and then come back, and if you go to the next one, they are not hitting anymore.
Right.
So then I could say, based on this objective data, the medication was probably helping with the hitting. But if you go back and you look at repetitive phrases, at first, when they weren't on any medications, they were having repetitive phrases somewhere between 5 and 30 times a day. And now that they're on the medication, or this might be 2 different scenarios, they are actually having repetitive phrases somewhere between 60 and 100 times per day. That might be important to say, hey, this medication is helping with the hitting, but maybe it's making the repetitive phrases worse. And then you have to sort of step back and think, is it the medication that's causing the repetitive behaviors to happen more often? Is it actually, hey, instead of hitting, they actually now have time to think and do the repetitive behaviors? Is the repetitive behaviors an important target for me to hit? Or was repetitive behaviors actually really important to me, and the hitting was so light that, yes, the hitting isn't happening anymore, which to you as a healthcare provider looks great. But for me, the hitting really wasn't a big deal, but the repetitive behaviors really is stopping the individual from doing what they need to do on a day-to-day basis. Maybe let's reevaluate what we're doing and think about whether or not we can target those repetitive behaviors less. And sometimes that might mean increasing the medications because you haven't hit the point where you're going to actually help the repetitive behaviors. And sometimes that might be deciding that that medication is actually not correct for the symptoms you want to target at this moment.
So I'm going to take an audience question because I think you're explaining it right now, the reality of these types of medications. And that question is, what should I do if I try a couple medications and they don't work? Should I consider trying another or just conclude that medication isn't for me?
So it depends, right? Every single time that I go through a medication trial and I say this medication doesn't work, I'm going back and formulating the issue. Right? I'm going back and thinking what's going on in your environment, what's going on with the expectations, what's going on in your lived experience. Is there something else we're missing? Okay? Then I think about my target symptom. Did I choose the right target? And then I think about what happened on the medications that made it not work. Is there did I need to do just one medication at a time? Did I need to combine a couple medications? Was I not choosing the right target? One of the really weird things about my psychiatric medications is you might have all these medications that are in the same class, but for some people one medication in one class works and some people another medication in another class might not work. So it might be worth trialing another medication. The other thing that sometimes happens is as our brain matures and grows, what might not have worked for us when we were younger might be worth it to go back again and look at to see whether or not it might work in the future. My big advocacy is medications do not do everything. You have to take that objective view to see whether or not they're making an acceptable amount of change, but you also have to take that objective view and say, okay, now that there's a little bit of change, what else can I do to help these symptoms improve? Now that the medications have helped a little bit, do I need something like therapy to help me change? Do I need something like behavioral treatment to help me change? Do I need something like a psychoeducational testing or an occupational therapist to come and help me understand what might be different? So an example that I might give is someone with OCD. They might be on a medication, but the gold standard of OCD, even in autism, is medication and something called cognitive behavioral therapy. And so I might be working with OCD on their medications, but I'm not able to do the cognitive behavioral therapy, and I might say, hey, we got you on this medication, so there's a little bit of help, but it's really not going that far. Let's see if we could do medications in combination with cognitive behavioral therapy to get rid of your symptoms. But truth be told, in this scenario, medications isn't going to do everything. You actually have to do two things in combination. It might be two medications in combination. It might be two treatments in medications. But as I said in the superhero slide, medications don't do everything, but they have a role.
And I guess the question that I would be asking myself if I was this person or anyone on this presentation is was this the process that I went through before I was first given my medication?
So sometimes you might be in a situation where you actually say, hey, we tried the medication, but I was really quick to get off of it because I had really bad headaches on this medication. And when you sit down and you talk to the doctor might say, hey, those medications might only last so long. Why don't we try repeating this medication? We'll give you some help with the headaches for the first few weeks. And then after that, hopefully that side effect might go away and we might be able to increase or change it. One caveat that parents often talk to me about and individuals often talk to me about is for whatever reason, people with autism do tend to have more side effects to medication than people without autism. And in my practice, I see the most bizarre side effects that are not on any labels, side effects that I would never expect. I trust that those side effects are happening because I don't think anyone has a reason to make up side effects. So as someone who sees a lot of people with autism, I advocate for doctors to listen to the bizarre and weird side effects, because if you decrease the medication and the side effects do go away, it might actually be because of the medication. Right. So be clear in communicating what's going on with the medication, or why you went off the medication, because it might actually be worthwhile to try again, because you might have not have done it in such a systematic way that can actually help you understand whether or not the medication is helping or not.
Do you have any specific experience or tips for supporting clients through the negative side effects, such as waking?
Waking, yeah, I wish.
So I wish. Did you say I wish?
Yeah, sorry.
No, but I mean, it's
it's real, to me, it's really sad, the side effects that happen, and I wish I had cleaner medications. I really wish I did. You asked the question earlier about natural medications. Yeah. Natural medications have side effects. Psychiatric medications have side effects as well. You have to look at why is that person having that side effect. So certain medications trigger that part in your brain that say eat. And anyone who took this medication, that part in their brain would say eat more, eat more, eat more. Some of us have better control for how much they eat than others, and some of us have that trigger in our brain that says eat, and we're really good at saying, hey, stop eating, and we don't eat even though the medication is telling us that we're still hungry. Some people don't have that trigger in that brain, and it's really hard for them not to eat. So what I say is think about what can you do to help the person manage the side effects, as opposed to how can I make sure that the side effect doesn't happen. So for example, with weight gain, you can't gain weight unless you're eating. So it might be a situation where if there's, if you're being put on a medication that you know has a weight gain as a side effect, you might say, hey, let's start exercising more as a family, let's start eating healthier, let's get rid of a lot of the junk food in our house, so the individual might not have access to it. That being said, I've seen people in hospital gain a ton of weight in a very short period of time on some of these medications, even with the best efforts. So my encouragement is try the healthy eating, try the exercise. Sometimes we're just stuck and we don't really know what to do about the weight gain. And once you gain weight, it's often really hard to lose it. The other thing that parents often tell me is, ha ha ha, healthy eating. This is a child that only eats bagels, pizza, chicken nuggets. And if I try to give any other food, I'm going to get hit. It's just not going to happen. And my child is just going to get even more irritable because they're so hungry all the time.
This is not coming down to, you got to pick the one, you know what I mean? You got to pick what you're going to go after. And, you know? And
sometimes, unfortunately, I wish we didn't have to, but sometimes we have to say, hey, they've gained a lot of weight. But this is the best quality of life that this person has had. We just have to live with that. The other thing that you might be able to do, or you might be able to talk to your family with, is if the situation is calmer, you might be able to switch to a different medication that has less risk for weight gain. If I can give an example.
Sure.
I had a person in my practice who had autism and intellectual disability, who had an incident with their family. A family member passed away. And they were having lots of aggression and difficulty with their parent passing away, understandably so. But the aggression got to the point where people were really seriously getting hurt on a day-to-day basis. And someone put them on a medication, very well-meaning, and the aggression did go away. This medication is a medication that can cause your appetite to increase. So then what happened slowly over time is the person started to mourn their loss of their parent and was actually able to move forward from their loss of their parent. What started happening was there was aggression over food-seeking behaviors. So this person was constantly looking for food. All the cupboards were locked, and they were hitting, punching, and kicking because they were always hungry. Okay? I told the parent, hey, let's switch medications. Let's try a medication that has less appetite stimulation, and let's see what happens with the aggression. At the same time, I said, hey, instead of having your this person look for food all the time, why don't you give them small amounts of healthy food at regular intervals to see if that is also going to help them satisfy their need for hunger, because their brain is telling them that they're hungry all the time. And with the combination of the behavioral technique of saying, okay, we're not going to limit access to food, we're just going to limit access to portions and unhealthy food, and taking away that medication but replacing it with another, because they still did have quite a bit of aggression, so they still didn't need the medication, but by choosing a medication that had less appetite stimulation, the aggressive behavior went away because they were no longer food seeking. That being said, sometimes we try the medication that doesn't stimulate appetite as much or has less side effects, and the sad truth is sometimes those medications aren't as good as the medications that have all the side effects.
Unfortunately.
Yeah.
Okay, we are running out of time, and so I want to burn through a couple questions, and then I want to wrap us up.
Should we go on to the evaluation slide as we're burning through these questions?
Yeah.
Because I think that goes along with some of them.
Real quick, I can probably answer this for you. I mean, do families ever ask you about non-evidence-based approaches? And I guess if so, what do you say about those?
Yeah, so yes, they do.
Of course.
You know, I could only work within the evidence that I have. One of the things that centers like CAMH and Holland Bloorview are doing is looking at different approaches to see whether or not they can have evidence. And it might be, say, hey, I can't endorse that. I can't endorse that because I don't know the evidence behind it, or I don't know if it's effective. You have your child and you have the N of 1. If it's important to you to try and it's not causing more harm than good, try it.
Yep.
And if it doesn't work, get out of there, right? Just like I said, do an evaluation for medications, do an evaluation for other therapeutic techniques, monitor the symptoms over time. If it's not working, don't waste your money, move forward. But if it is working, then that might actually be something that's really helpful for your child.
Anecdotal evidence does not work in this case. Do you see it common, or do you have any strategies for children indicating they don't want to take medication?
How to get your... So there's a few issues with medication, okay? There's how do you swallow that pill? How do you swallow that liquid that tastes really bad, right? How do you convince your teenage child that they need a medication, right? So how can you convince your adult person that you need to take a medication? So what I like to do is again, I'm taking that step back and thinking about why does this individual not want to take medications? Can they not swallow a pill? If they can't swallow a pill, is there a technique that we can use by starting off swallowing Tic Tacs and then slowly getting bigger to help them learn how to swallow a pill? Can they not tolerate the taste or the texture of the pill? Is there something that we can do to change or modify the taste or the texture to make it easier? Is there a reason why they don't want to take a pill? Do they think there's a stigma that has to do with the medication? Do they think that you're just trying to fix me, or there's nothing actually wrong with me? And helping your child understand why you wanted them to take the medication might be helpful. And then the last thing that I think about, is there side effects that might be causing the person not to take the medication? And if those side effects are causing the person not to take that medication, that means for the individual, the side effects do not overweigh the benefits. So how can you help the benefits actually outweigh the side effects, either by choosing a different medication, choosing different approaches? But you know, you can't pin a child down and put a medication in their throat, right? You have to do it as a collaboration, and figuring out how to make it as collaboratively as possible might take time, but it's worth it to put the time and the effort into the collaboration so that eventually you can at least try a medication.
Excellent. So with that, I'm going to give you an opportunity to wrap up. Have we handled this evaluation stage, or do you have a few comments about this?
I think it was a good thing to have in the background as we were talking about that last slide, but I think we've done it. I think the most important part for evaluation is think about what positive effects are having, what negative effects are having. Is the positive outweighing the negative? Is the negative outweighing the positive? Do I go up on a medication? Do I go down on a medication? Do I add a medication? Again, the best way to do that, to figure out what the right solution is use objective data. So you could communicate with your healthcare provider, not just say, I think or I feel it's working, but hey, it's working, and here's the objective data that I have to tell you why. Hey, it's not working, and here's the objective data that I have why. And except that the healthcare provider might have had a separate target and have that conversation with the healthcare provider. Oh, actually, your target was this? Oh, I didn't know that. Maybe we can go back and look to see if that symptom actually did make a difference. That being said, always discuss all medications with a healthcare provider. This is an approach that you can use. You can go to the primary healthcare guidelines to sort of show that there's evidence for this approach. It might be your healthcare provider might not have time to go through the whole approach with you, but before you see your healthcare provider, you could even on your own sit down, think about the different reasons why this individual may be acting the way that they're acting. Present it to them and have a discussion when you're going up on a medication, when you're going down on a medication, when you're stopping a medication or starting a new medication. This should be something that you don't do just based on today's talk, but you do based on a conversation with your doctor, nurse practitioner, whoever your healthcare provider is.
Very important last words. It is a collaborative process, as you said many times. There's a number of people within the circle of care. With that, we are just over the time limit, so we had a lot of good stuff. This webinar will be archived and available on the Autism Ontario website this time tomorrow, if not before. Feel free to take this same link and share it with any of your friends, family, loved ones, anyone that you think is important or who would find this valuable or important. I think not just those on the spectrum, actually. It was a great presentation. The more people we have through this program, the more programs we're able to offer you, so please feel free to share this. Hit the resources before you leave, and we'll see you next time at our next Autism Ontario event.